So, good evening, everyone. Once again, we all meet today in the month of April for our session. It's a very important topic. Two important topics will be taken care today. One is RA strategies for shoulder and clavicle fracture by Dr. Bhuvana from Ruby Hall Clinic, Pune, under guidance of Dr. Amit Dikshit sir. And second will be a journal club discussion on facial plane blocks by Sri Shravan from Ganga Hospital, Coimbatore, under mentorship of Vipin Goyal sir. Now, as we all know that we have special moderators for today's session, Dr. Azam Danish sir and Lakshmi Priya ma'am. I welcome both of them. Going ahead, we all know Azam Danish sir from our student days for going through all his notes. Sir is a faculty at consultant anesthetist at Bhagwan Mahavir Jain Hospital since 2001. Sir is board of director for Aora PM, a proud moment for us. He is also founder and chairperson of Bangalore Anesthesia Review Course. He is a Aora executive member and we all are fan of Sir's photography skills. He has a special interest in USG guided nerve blocks for vascular surgery anesthesia, anesthesia for ops and spine surgeries and critical care. I welcome Azam sir for today's session. Sir will be joined by uh, Lakshmi Priya ma'am, Lakshmi ma'am, yeah, Lakshmi Yelavarti ma'am. She's clinical HOD anesthesia department AIG Hospital Hyderabad. Ma'am is a ABA certified cardiothoracic anesthesia. Ma'am's area of interest include cardiac anesthesia, TE and regional anesthesia and major onco and HPB fellowship. Ma'am has done her ABC certified cardiothoracic anesthesia from Cleveland Clinic. Welcome ma'am. Thank you for joining today's session. Can you share your PPT, Dr. Bhuvana?
Yes, ma'am. My presentation is visible, ma'am?
Yes, yes. You can go ahead, Dr. Bhuvana.
Okay. Good evening to everyone. Today I will be presenting about the topic of regional anesthesia strategies for clavicle and shoulder surgeries. I am Dr. Bhuvaneshwari, ORF Fellow from Ruby Hall Clinic, Pune. Before we enter into the strategies, we have to know about the anatomy of the clavicle and shoulder things. So clavicle is a sigmoid-shaped long bone. Unlike most of the long bones, it is typically lack of medullary cavity and it's mainly rely on the periosteal blood supply. The arterial supply of the clavicle is suprascapular artery, thoracoacromial artery and internal thoracic artery. And next important thing we have to know is nerve supply of the clavicle. The innervation of the clavicle, it's a crucial and overlapping because it has dual innervations with the two different plexus. One is from superficial cervical plexus, other one is brachial plexus. The anterior and superior aspect of the clavicle is entirely supplied by supraclavicular nerve from superficial cervical plexus, and posterior and inferior aspect of the clavicle, it's supplied by nerve to subclavius and lateral pectoral nerve. In the medial aspect of the clavicle is minor contribution with the spinal accessory nerve, and laterally we have a suprascapular nerve and with a minor contribution of axillary nerves. This is a nerve supply. So already discussed with the image. I want to discuss one thing. The supraclavicular nerve, it's from C3, C4 nerve root of superficial cervical plexus, and subclavian nerve from C5, C6 upper trunk of brachial plexus, and lateral pectoral nerve from lateral cord of brachial plexus from C5, C6, C7 nerve root. The other thing is muscle attachment. We want to know the muscle attachment of the clavicle. The clavicle is divided into three parts: medial 1/3, middle 1/3, and lateral 1/3. In medial 1/3, it give attachment to the sternocleidomastoid in superior aspect, and inferiorly it give to the subclavian muscle, subclavius muscle in subclavian groove. Anteriorly, it's give attached to the pectoralis major and posteriorly sternohyoid muscles. And middle one third, it's free of muscles in a superior aspect, and inferiorly it is continuous subclavius muscles, anteriorly with pectoralis major and posteriorly with the sternohyoid muscles. In lateral one third, the superiorly it gives the trapezoids, and in inferior aspect it gives costoclavicular ligament in the groove, and anteriorly it gives attachment to the deltoid muscles, and inferiorly it gives insertion of trapezius posteriorly. So why clavicle anesthesia is still challenging? Because the clavicle is have a dual plexus innervation with a variable anatomy and poor diffusion of local anesthetic. So combination or along with the target block is required still. So no single block is cover all the zone reliably. Regional anesthesia strategy for clavicle, the techniques can be divided into two. One is plexus block with interscalene blocks, superficial cervical plexus, and selective superior trunk, scud blocks. In facial planes, we have clavipectoral facial planes. Before we go into the blocks, what are the things need to prepare before proceeding to the blocks? One is we need to get a informed patient consent, adequate IV access, and we need to attach the ASA standards monitoring. We need a skilled assistance, emergency drugs required, and appropriate probe with USG machine, a blunt tip echogenic needle with a 50 to 100 mm depth based on the scout scan examinations with a 22 gauge needle, and local anesthetic and adjuvants, and sedation based on the patients and based on the procedures. We'll go with the midazolam, opiates. In other entity, we can go with the TCA remifentanil. In our institute, we commonly use 1 mg midazolam, 50 fentanyl, or otherwise we'll go with the TCA remifentanil 1 to 1.5 effect site concentrations. Then other thing is superficial cervical plexus block. So in superficial cervical plexus block, we need a patient in supine, head to be turned contralateral side, so area to be prepared with a 0.5% of chlorhexidine. In that, with the help of linear probe, we need to place in the linear probe in the posterior edge of sternocleidomastoid muscles at the midpoint. Then we can see the tapering end of the sternocleidomastoids. Drug need to deposit just superficial to the investing facial layer of cervical fascia. This are anatomical cut sections. We can see this investing layer of deep cervical fascia. In superficial plexus block, we need to deposit superficial to this. In intermediate cervical plexus block, we need to deposit in between the investing layer of deep cervical fascia, and in deep cervical facial blocks, we can go with just superficial to the prevertebral fascia. This is a dermatomal coverage of the superficial cervical plexus blocks. This is a study, it was published in 2025. In that study, they found effect of USG guided one group they taken as a superficial cervical plexus block with clavipectoral facial plane block versus the group 2 is superficial cervical plexus block with interscalene for clavicle surgery. In that, the primary outcome of the study they taken as duration of analgesia and comparison of time to first rescue analgesia. In the group 1, that is clavipectoral facial group, they have quite longer duration of analgesic part, and rescue analgesia is also recommended significantly lower compared to the group 2. So they concluded that it is a safe and effective anesthetic technique for clavicle fixation surgeries. Superior trunk block, the other entity of block for clavicle surgery is superior trunk block. It is a reliable block. We are blocking C5, C6 nerve root of brachial plexus. It provides analgesia at the same time anesthesia for surgery. The hemidiaphragmatic risk is approximately 5% when compared to the traditional interscalene blocks. It is 70%. So in the block, we need to block distal superior trunk block to avoid the phrenic nerve involvement. The perform just proximal to the takeoff of uh, just proximal to the takeoff of suprascapular nerve to cover the ensure adequate surgical coverage of the shoulder also. In the proximal block, if you block just C5, C6 just meet to form superior trunk. The spread of drug medial is more, possibility of drug spread medial is more. So in that, the phrenic nerve involvement is chancer with the proximal, so we'll prefer distal superior trunk blocks. This is a video. In that you can see this is the superior trunk. It divided into anterior and posterior division along with the suprascapular nerve just run behind the belly of omohyoid. This is spa arrangement. In this area we need to deposit the drug. In the diagram there is a upper trunk. There is an anterior and posterior division. Just take off of the suprascapular nerve. The area of interest of drug depositions here. There is a study was conducted in Wang et al. It was published in 2021 from the ortho journals. In that they found effect of a low volume ropivacaine with a lower concentration in superior trunk block. They found out diaphragmatic movement was preserved. The patient who undergoing shoulder arthroscopic surgeries. In that, they found two volumes comparison of 50 ml versus 10 ml with a concentration of 0.2% of ropivacaine. They found the analgesic part is not compromised in that, but the duration of analgesia and effectiveness of analgesia was comparatively better with compared to the 15 ml, 10 ml we can attain with this analgesia part. Next block is cut block. Cut block is nothing but selective blocking of supraclavicular nerve with upper trunk of brachial plexus. It's mainly site-specific regional anesthesia. This is one of the strategies for clavicle surgeries. Why it was developed? Because in traditional approach, if you're going with superficial cervical plexus with interscalene block, we are blocking too many nerves, which is not specified to the clavicle actually. So scud block, we are mainly targeting the four nerves which anatomically responsible for the clavicular pain. In that, Shivashanmugam sir's study was conducted in that. Based on that study, they concluded the supraclavicular nerve blocking 3 ml of local anesthetic with upper trunk is 5 ml. It's a towards site-specific regional anesthesia strategies for the clavicle surgeries. So one more study, it was conducted and published in 2024. In that, the two group of uh, nerve blocks was conducted. One is supraclavicular nerve with upper trunk brachial plexus, that is cut. Other one is clavipectoral fascia with selective supraclavicular nerve blocks in mid shaft of clavicle fracture surgeries. It's a randomized control study. In that, they found the scud block have longer duration of analgesia irrespective of lower volume, and in CPFS group was better shoulder movements because in that they are not blocking any motor movements of the nerves. So better shoulder movements we can allow daycare surgeries. So both the blocks have similar success rate, onset of time and procedures the time. The other facial plane block is clavipectoral facial plane blocks. The first, it was described by Valdez Witches in 2017. This is a facial plane blocks. We are mainly targeting the drug was deposited between the clavipectoral fascia and clavicle periosteums. In that, they found the drug. In the cadaveric study, they found that the stain was failed to stain in the posterior inferior aspect of the clavicle. Then started they doing inject the drug in between the pectoralis major and subclavius. They found that the dye was trained in the posterior inferior aspect of the clavicle also. Why we need to give clavipectoral facial plane block? Rather than blocking proximal plexus element, motor blockings, we are only blocking the terminal periosteal ending nerves only, so circumventing the proximal variable anatomy. In that, this study was conducted in Ganga Hospital, Coimbatore. In that, they modified clavipectoral facial plane block for rescue for polytrauma patients with along with brachial plexus injury who undergoing awake clavicle surgeries. In that, they concluded it's a better alternative to general anesthesia in other available regional anesthesia techniques to provide its mainly surgical site, its concurrent in it's incision concurrent surgical anesthesia. For and also they concluded it is a post-op analgesia for and await clavicle fracture surgeries, especially in polytrauma patient with brachial plexus injuries. The clavicle regional anesthesia strategies summaries. These are the blocks with the clinical scenario with alternative blocks and hemidiaphragmatic involvement. In healthy patients who undergoing ORF for clavicle, then we can go with the superficial cervical plexus plus interscaleni. In that point, we'll give dense surgical anesthesia plain for the patient and surgeons. If you want to go with the alternative things, then we can go with superficial cervical plexus plus superior trunk blocks. The if you prefer surgical dense anesthesia, so 100% diaphragmatic risk will be there based on the scientific evidence. If the patient is planned for awake mid shaft of clavicular ORF, then plan of anesthesia is modified clavipectoral facial plane blocks plus superficial cervical plexus or selective supraclavicular nerves. In that, the incidence of hemidiaphragmatic involvement is almost zero. The patient with a COPD, then we have to preserve the phrenic nerve involvement in the blocks. So, superficial cervical plexus plus clavipectoral facial plane blocks is a better option for the patients. So, we can reduce the incidence of phrenic nerve involvement. If the lateral one third of fractures, that times we need to cover the brachial plexus also. In that, we can select superficial cervical plexus block with superior trunk, or otherwise we can go with scud blocks. The incidence of diaphragm involvement here is low. The next topic is regional anesthesia for the shoulder. What are the choice and technique available for regional anesthesia for shoulder surgeries? We have interscalene, supraclavicular, costoclavicular, or infraclavicular, or we can ask the surgeon to infiltrate the local anesthetic in surgical site, and we can go with the selective nerve blocks like supraclavicular along with the axillary. What is your practice for regional anesthesia for shoulder surgeries? Either plan GA alone or local infiltrations or blocking the plexus above the clavicle or blocking the plexus below the clavicle or selective axillary nerves plus supraclavicular or single shot or continuous is based on the patient decision, surgeon and resources available. When we planning for anesthesia for a shoulder, we need a structural strategies along with the five key factors. One is we need to know about the anatomy and procedures, whether it is a daycare procedure, ambulatory or minor, and patient factor, especially if the respiratory compromise and surgery, whether it is open or arthroscopic, based on the resources, we need to decide the nerve block strategies. So shoulder innervations, the key nerve is suprascapular nerve. 70% of capsule is supplied by suprascapular nerve, and with the minor entity with the axillary, lateral pectoral nerve, and suprascapular nerve, and supraclavicular nerve, and intercostal nerves. The core challenging here is balancing anesthesia against hemidiaphragmatic risk, especially in a patient respiratory compromise. The genohumeral joint have multiple innervations, so that's why single injection can't provide complete regional anesthesia or surgical anesthesia to the patients. So here we can see the diagrammatic representations. And through the posterior superior part of the shoulder is supplied by suprascapular nerve, and anterior inferior part is axillary nerve. The anterior part is minor contribution with the lateral pectoral nerve, and anterior and deeper structure is supplied by lower subscapular nerve. This slide is highlighting the core clinical problem of the shoulder anesthesia, because phrenic nerve relationship to the upper trunks and brachial plexus things. Here you can see the left side of the image. This is the uh, anterior scalene muscle. This is a phrenic nerve. This is a upper trunk. This is a middle trunk. This much of close proximity of phrenic and brachial plexus. Even if you inject, very low volume in USG guided 5 ml, it will spill over the anterior scalenus. The phrenic nerve might got blocked. Even if you injected 4 mm away from the light, paraplexus block, the chances of blocking of phrenic nerve is we can reduce, but we can't eliminate the blocking of phrenic nerves here. In the USG image, you can see the how much the close proximity. This is a brachial plexus, this is an anterior scalenus, this is a medial scalenus muscles, this is a phrenic nerves. Whenever you try to inject the drug here, it automatically spill over the anterior scalenus muscles. The chances of blocking of phrenic nerve is more. In case, if you block the phrenic nerve, it will reduce 20 to 30 percentage of forced vital capacity and FE1 in it's subclinically normal in healthy patients. The patient with contralateral phrenic nerve involvement or patient with severe COPD, morbidly obese patient might end up with a respiratory failure. And accessory phrenic nerve, why we know about accessory phrenic nerve? What is the clinical importance of this nerves? It is mainly formed by ans of cervicalis and subclavian nerves. It is rarely to also been arise from C3, C4 and C5 nerve root. If you planning phrenic nerve strategies, if you planning to do the case in phrenic nerve strategy, irrespective of that, might block the accessory phrenic nerve. The patient might end up with a reduced diaphragmatic movements in the anatomical variation of the accessory phrenic nerves. The accessory phrenic nerve most commonly join with the phrenic nerve within the thorax or one third of the patients within the neck in various locations. So we can't predict the accessory phrenic nerves. That's why phrenic nerve strategies technique is not completely eliminate. We have a residual hemidiaphragmatic risk. The other entity is surgery. Surgery wise, in arthroscopy surgery, we have moderate to severe pain based on the procedure, whether it is open or arthroscopy and type of arthroscopy we want to know. The repair, the patient will have more postoperative pain compared to the decompression arthroscopy and rebound pain. The rebound pain is nothing but it's acute transient increase of pain intensity once the block effect is weaned off. It usually occur in after 24 hours or within 24 hours of time, usually at the night time. The numerical rating score is usually more than or equal to sevens. The factors include in the rebound pain is the young females, the preoperatively patient have severe pain. The in case we might not include the dexamethasones in our stock solutions, the patient might develop rebound pain. In patient factors, we have to know about the how long patient is preoperatively pain and catastrophic any history is there and history of smoking, and we have to know about the lung compliance status and preoperative pain tolerance. Based on that, we need to decide the anesthesia strategies. So in this expectation setting regarding the pain control is the key idea is set the expectations before surgery to the patients, what kind of patient, what kind of pain will be there after surgery. Some pain is normal even if anesthesia was well worked. And what type of nerve block is planning to the patient, we have to inform to the patients. And the duration of analgesic block is limited times. Once block is been off, the pain can increase, then we need to inform to the patients multimodal analgesia is required, request, irrespective of anesthesia is work well. The patient might require continuous infusions, and it may be the team coordinations with the surgeon, anesthesiologist, patient, and family members, what drug and when to give, when in which mode of need to give. Everything need to be discussed to the patients before surgery. Interscaleni blocks have a study that was meta-analysis was conducted with 6 randomized control study. In that they found extrafacial interscalene block reduce the incidence of hemidiaphragmatic risk but does not eliminate the hemidiaphragmatic risk. In that I included C5, C6, C7, 8 also. I'll explain in the next slide, why I include C8 also in the interscalene for shoulder surgeries. This the first randomized trial was conducted. In that they found effect of C8 nerve root during the interscalene brachial plexus block for anesthesia of posterior shoulder, the patient undergoing shoulder arthroscopic. In that they found the C8 nerve root. We are not usually blocking C8 interscalene brachial plexus block for shoulder. In that they found consistently there is a sparring in the area of posterior port. So, based on the Keegan and Garrett's dermatomal map, in that they found the C8 is in dermatomal mapping was C8 was supplying the shoulder in the posterior.
Just two or three screw they will.
Yeah, you continue.
Okay, sir. The C8 nerve root, usually we are not blocking in the interscalene block for shoulder, especially. Rarely we are performing because that is challenging and visualizing and blocking in interscalene C8 root. The Keegan and Garrett's map was assessed a sensory blockade produced by the interscalene brachial plexus block, which is consistently sparring in the posterior aspect of the shoulder. According to the Keegan and Garrett's, the posterior shoulder was innervated by C8. In a Foster dermatomal map, that is C5, but in Keegan's, they mention like it's a C8. So it's a first randomized trial to investigate whether it is effectively reduce the pain intensity in the posterior port of the shoulder and whether it is improve the quality of surgical anesthesia. In that, they found it will reduce pain intensity and also quality of surgical anesthesia is improved if you block C8 root. What is soft point injection? Soft point injection is nothing but if you not include C8 nerve root, that time we have to inform to the surgeon, ask the surgeon to infiltrate the local anesthetic before they put the port. That is 1 centimeter inferior, 1 centimeter medial and 1 to 2 centimeter inferior to the posterolateral aspect of the coracoacromial joint, where exactly surgeon will put the posterior port. This is superior trunk block for blocking, preferring phrenic nerve sparing for shoulders. In this a meta-analysis, they concluded that it is analgesic part is equivalent and it's a safety and it is superior safety profile in term of respiratory compromised patient. This is superior trunk. This is distal superior trunk. So it is far away from the phrenic nerves. So if you deposit the drugs here, the chances of phrenic nerve involvement is very less. The other block is suprascapular nerve. There is two approach. Either we can go with the anterior approach or posterior approach. In anterior approach, they were very much limited to the volume based on the cadaveric study. The minimal maximum effective volume is less than 4.2 ml. This cadaveric dissection. In that, they'll conduct two things. One cadaveric, they'll inject 5 to 10 ml. They see the spread of dye from supraclavicular to phrenic nerve involvement. In that, they precisely inject 4.2 ml. In that, we'll see only suprascapular nerve got involved. The phrenic nerve is free of stents. The pathway of phrenic nerves get involved. There is a dye was tracking along the posterior sheath of dorsal aspect of brachial trunk. It spill over the phrenic nerves. Based on the studies, we limited to the supraclavicular anterior approach limited to 4 to 5 ml. This is a one more study. In that study, they found that analgesic part and rescue analgesia and preservation of vital capacity with a comparison of interscalene, supraclavicular and anterior suprascapular. In that they found it is not inferior to the interscalene in the analgesic part and rescue analgesia, but one of the best thing they found out in that the vital capacity preservation is more with anterior scalene compared to the interscalene groups. The posterior approach of suprascapular nerve blocks in that when you inject the drug in the suprascapular notch, that will carry the pneumothorax risk because the chest wall is just anterior to the location of suprascapular notch. In that, based on the ASRA 2025 guidance, they prefer to block sphenogynoid notch approach in the patient with severe lung disease to reduce the risk of pneumothorax while needling. Here the area they're marked here, the red box is suprascapular notch, the blue one is sphenogynoid notch. If you block here, the analgesic part and anesthesia part is same, but we are reducing the incidence of pneumothorax here. The limitation with the posterior suprascapular nerve is there is inferior analgesic compared to the interscalene, but we can best combine with the axillary nerves or infraclavicular brachial plexus block to attain the analgesic part. This is selective axillary nerve blocks. We are mostly blocking in the quadrangular space. What is the drawback with a selective axillary nerve block in a posterior approach? Because most of the motor innervations of axillary nerves was branched prior they enter into the quadrangular space. That is nerve to subscapular, teres minor, and major. These branches are branched out before they enter into the quadrangular space. Once you're blocking the posterior approach, can provide incomplete analgesia part along with the suprascapular nerves.
7:30.
So few more slides left now.
Yeah, please continue.
Yes, sir. This is supporting evidence of the study in that anterior, selective axillary nerve blocks was conducted along with the suprascapular nerve. In that, they are concluded that it is not a purely surgical anesthesia. We can use as a analgesic part. This is an anterior axillary nerve approach. This is a newer technique. It's anterior axillary nerve approach. We need the patient in a supine. Arm should be side of the thoracic wall and forearm should be pronated just spaced over the abdomen. Place the probe just below the parallel to the clavicle. First identify the coracoid process and lesser tubercle. Then the patient arm should be abducted and externally rotated, and the medial side of the probe is just rotated inferiorly to obtain the sagittal oblique view. In that you can see the humerus head, subscapularis tendon, and deltoid, pectoralis major muscles, and you can see the axillary artery, first part of axillary nerve also. So in that part, if you're blocking here, we can attain the complete analgesic part of the shoulder with the axillary innervations. This is a video. You can see this is the head of humerus. This is a subscapularis tendon. This is a deltoid muscles, pectoralis major. Here you can see some pulsatile arteries there. This is the anterior circumflex humeral artery. Along with that, you can see the nerve here. That is the first part of axillary nerve.
Wow.
So block assessment. So specifically with the clavicle, that is a we are blocking on the cutaneous nerves. The cold sensation over the bone we have to check. If you're blocking the brachial plexus, the cold sensation over the tip of the shoulder, and usually with the brachial plexus, we usual techniques push, pull, pinch techniques. Along with that, you have to check other things. Patient able to abduct the arm, elbow flexions for a motor, and axillary nerve we need to separately with a deltoid muscle sensation over the deltoid muscles, and suprascapular nerve with a motor strength of supraspinatus, infraspinatus that can be elevated internal rotation, external rotation of the shoulders. If the patient have breakthrough pain, it is isolated in a single region. We ask the surgeon to infiltrate over there. If the pain can't localize, if the toxic volume is not crossed, we can reattempt the blocks. If nothing works, surgeon is started, we can go with with moderate sedation or remifentanil infusion, TCA. So the one more things we need to worry about here, the phrenic nerve involvements. So we need to assess a diaphragm assessment here. So we need to place a curvilinear probe just the subcostal region. 15 to 30 minutes after our block, we need to check. Diaphragm excretion is quite breathing. Normally 1 to 2 centimeter we need to. In a deep inspiration, it should be 3 to 5 centimeter. In sniffing test is more than 1.5 centimeter of thickness. So other entity is thickness. Normally in the zone of opposition, we need to see the thickness more than 20% during inspiration is considered as normal. This is a block. After block costoclavicular, we assess the diaphragm. Even with a 20 ml of costoclavicular block, we'll see the diaphragm exclusion was drastically reduced from pre-op in post 30 minutes of the blocks. Surgical anesthesia using regional anesthesia. These are the part we need to cover for the shoulder. For a skin or port infiltration, selective supraclavicular nerve or superficial cervical plexus block. For a joint, we need to cover suprascapular plus axillary nerve. Either we can go with superior trunk or interscalene blocks. For deltoid muscles, we need to block the axillary nerve with selective axillary nerve blocks. And medial arm of the, we need to separately infiltrate T1, T2 intercostal brachial nerve. And acromial joint, same, it has a minor contribution with the supraclavicular nerve. We have to block superficial cervical plexus plane. This is shoulder strategies based.
Bhuna, it's already 35 minutes. Can you
Yes, sir.
finish up the, yeah,
Yes, sir.
we need time for discussion.
Okay, sir. Then I'll discuss only few things in a recent shoulder pain. We are only blocking the terminal branches. Main thing is there is no phrenic nerve risk. Motor sparing we can attain with this. This is one of the new block, infraspinatus teres minus interfacial plane blocks. In that we are blocking with the single injections. We can cover both suprascapular plus axillary nerves. This is anatomical dissections. In that, if you inject the drug in this plane between the infraspinatus and teres minus, you can attain both axillary nerve and suprascapular nerves. And other one is recent is subhomoid brachial plexus block. In that we are blocking only upper and middle trunk at subhomoid level. The phrenic nerve is sparing is very less because we are dealing with the cord levels. And one more is erector spinae block for post-op pain. It was conducted by Sandeep Diwan sir. Based on the volume, we can go with the continuous infusions or with a single injection, 20 to 30 ml, 0.2% BPVK, we can attain the post-op analgesics. This is a prospective guidelines for the rotatory cuff repair. In that, the grade A is a strong evidence. We can go with interscalene block, whether single shot or continuous. The grade B, we can go with the moderate evidence, suprascapular nerve block with or without axillary nerves. And the grade D is paracetamol or COX-2 inhibitors or opioid is a rescue analgesics. Thank you so much for your patience listening.
We will discuss this presentation, Azam bhai, so that because second presentation is entirely different, so we can have question answer session and comments from you and ma'am for this presentation.
Yeah, thank you. That was for me, directed towards me, Hetal bhai?
Yes. You
Okay.
and ma'am
Yeah.
both.
So, Bhavna, that was an excellent presentation.
Thank you.
There is no doubt. I think you covered, I'm sure Amit must have helped you. Really, you covered most of the points. What I want to understand is, what are the fibers that are seen in the phrenic nerve?
Sir, I'm not getting your question, sir.
What type of fibers do you see in phrenic nerve? Or phrenic nerve is made up of what fibers? What are the different fibers that you're aware of? A alpha, you have A beta, A delta,
Yes.
C fibers.
That is
Okay, fine, no problem. So this accessory phrenic nerve also you mentioned in your discussion,
yes, sir.
right?
Yes, sir.
So what is its prevalence?
The
Accessory phrenic nerve?
prevalence is 35 to 70% they mention in the article, sir.
Okay. If you go through that locus et al., that is 2006, he says it is found in 61.8%. So
Okay,
for
sir.
some reason, if you when you give a block,
Okay, sir.
somehow these patients will get away because they still, there is a accessory phrenic nerve,
Yes.
right? And bilateral occurrence is seen in about 39%, approximately. And what is the most commonest origin?
The origin is C2, 3. Sometimes it may involve C5 nerve roots also, sir.
Perfect. Perfect. So what is the beauty of this phrenic nerve? Suppose say you have given a block and the phrenic nerve gets blocked.
Yes.
So, I mean, what is its, the important function? How long do you think it will take to recover? What are the different ways to get back the phrenic nerve?
Sir. Usually, if you block the phrenic nerves in awake patient, the patient may complaining of difficulty in breathing most of the times. Normal healthy patient, mostly the patient can tolerate with this blocking, sir. Mostly the problem with the severe COPD patients or compromised lungs only we need to worry about. But it will be come back 3 to 4 hours. It normally settle down most of the time.
Okay. Correct. So basically, what you need to remember is the phrenic nerve is a continuously firing. It's continuously keeps firing, right?
Yes.
So the sooner it gets blocked easily, and also it is firing so much, it gets opportunity, it gets
Yes.
fired, and the recovery also is very very faster. So what I was trying to ask you is, see, it's important to know the phrenic nerve or the nerves involved. I mean, type of nerves that is involved. It has motor, sensory, and autonomic innervation.
Okay, sir.
So motor innervation is by A alpha and sensory is by A beta, A delta, and C fibers. But also important is C sympathetic fibers also, which is autonomic innervation. So these are the things that you need. So what happens is A alpha fibers carry motor signals to diaphragm. That is what we're worried about.
Yes, sir.
And they enable contraction of the, when you're breathing, respiration.
Yes, sir.
So larger diameter, they are heavily myelinated and fast conducting.
Yes, sir.
Right. Yeah, I think overall excellent presentation. Thank you.
Thank you, sir.
Just a last question. So,
Yes,
what are
sir.
the different ways of reducing this? You said couple of thing, right? Phrenic nerves block
Yes, sir.
in shoulder surgery. So, what
Sir.
do you think? Different ways of.
Sir, either we can prefer the lower distal brachial plexus approach with a lower
Uh-huh.
volume, with a lower pressures, and
Okay.
with precise to the ultrasound, we are go with the precisely which area need to be blocked. We can block specific to the specified to the nerves. We can block the individual things, either a suprascapular with axillary. We can eliminate the risk of phrenic nerve involvement.
Uh-huh. Correct. So if you have to I'm talking in terms of shoulder surgery.
Yes, sir.
If you literally have to reduce
Yes.
the phrenic nerve, what are the modifications that you can do in terms of volume, in terms of selecting the nerve that you want to block?
The
For
volume.
example, if you want to give a superior trunk block, for example,
Yes, sir.
what is the involvement of phrenic nerve? What is the percentage of phrenic nerve involvement?
So if you select the superior trunk block proximal, the chances of involvement is quite higher because of anatomical close proximity. So I'll prefer the lower distal SPT. The chances is 5 to 10%, sir, in that. If you with
Which
the
one? A superior trunk block?
superior trunk
I think
block.
one of the studies, I don't exactly remember, it was in 2023.
Okay, sir.
It is, I think, if I'm not mistaken, it is anywhere between 20 to 30%.
Okay, sir. Okay, sir. I'll go through
And
that.
if you give a C7 injection, the involvement of phrenic nerve is
Still lesser compared to the
13%.
yes, sir.
Periplexus.
I'm not
So
sure.
anyway, so you also showed a beautiful, focus on the diaphragm, right?
Yes, sir.
See, the problem with the diaphragmatic paralysis in blocks, when do you say it is completely paralysis? So when do you say that, okay, my block has definitely paralyzed the diaphragm?
So we have to look the zone of oppositions.
That
If
I agree. That is where you keep between
uh,
seventh and ninth rib, between the anterior and mid axillary line. Fine. See
the
when you
exertion is less than 0.5 or less
correct.
than 0.7.
So you call it as a complete paralysis is when it is more than 75% reduction in the
Yes.
diaphragmatic excursion
Yes.
as compared to baseline. So,
Yes, sir.
meaning what I'm trying to tell you is 75% reduction in the diaphragm, to call it as, it is such a vague number of 75, more than 75%. So even if it is 50%, you may not call it as a diaphragm. You may call it as a, partial. So partial diaphragmatic paralysis is anywhere between 25 to 75%. So anyways, the phrenic nerve gets, so what is the volume? Can you throw some light on the volume of local anesthetic and phrenic nerve involvement?
Yeah, yes, sir. Based on the article, sir, with the Shivashanmugam sir study, they quoted as a 5 ml for superior trunk blocks. The one more study was conducted in that they'll mention like 7 to 8 ml is sufficient to block the superior trunk. So routinely we are practicing like 10 ml, sir. We are blocking with a 10 ml of superior trunk distally.
And you found it still gets involved?
No, sir. We did few cases. After that, I'll POCUS done with the USG. Then involvement is very less compared to the pre-op and post-block. The excursion is not that much affected in that my patients.
All right. Excellent. Yeah. Thank you.
Thank you, sir.
Dr. Lakshmi, comments from your side.
Hi, Bhuvana. It's a very nice presentation. I think you covered almost all the areas and you touched all of them nicely. And very nice uploading of the self videos. I really like when you upload the videos that you have done by yourself. And I think Dr. Azam almost covered most of the things. So for clavicle surgeries,
yes, ma'am.
What do you practice? What kind of block would you give, and what was the success rate with the kind of blocks that you give for clavicle surgeries?
Ma'am, in our institute, we are practicing mostly with under GA. We are doing, ma'am, along with the superficial cervical plexus block with superior trunk blocks, ma'am, for post-op analgesia.
जनरल कंडीशन थोड़ी सिक ही लग रही है मतलब वार्ड
Yeah, Bhuvana, go ahead. Yeah.
Because here we are surgeons are very lessly posted the clavicle cases. We are not exclusively doing under blocks. Mostly we'll go with the analgesic part of the clavicle under GA only, ma'am.
Okay. Anyone has the experience here who has done clavicle surgeries purely under block?
Yeah.
The combination of the blocks that you feel like, works perfectly?
Yeah.
Ma'am, actually, I did one case.
Yeah, Dr. Vandana?
I can comment on it. Yeah, if I can comment on it.
Yeah,
we do clavicle surgery purely under regional anesthesia, and we give a
Madam, can't hear you, ma'am.
cervical plexus block using
Your voice is
can't
not
hear you.
clear.
Okay, just a minute. Can you hear me now?
Yeah,
Perfect.
Am I audible?
Yeah, it's better now.
Yeah. So what we do is we do it under intermediate cervical plexus block, USG guided, and we give about at the level of C4, we give about 3 to 4 ml of local anesthetic there, and we do a supraclavicular brachial plexus block with about 10 ml of local anesthetic, and we get away with it absolutely clean, no issues. Another comment I wanted to make was that in these strategies for shoulder, supraclavicular block was never considered. Whereas in our experience, we are doing it under, again, the same combination, 10 to 15 ml of local anesthetic in the subclavian perivascular and 3 to 4 ml in the intermediate cervical. And we get away with, although I'm not doing arthroscopy surgeries, I'm in the trauma center. So we do all types of shoulder injuries from clavicle to shoulder. So we do it under these two blocks and we get away with it very comfortably. We usually don't give sedation also.
Great. Thank you. Yeah.
Lakshmi, can I add something?
Yeah, please, Dr. Ajam.
So, one thing we need to remember when we are giving a block for clavicle fracture, we had these two cases where we had given a block, and because there is a clavicle fracture, there is a tear in the brachial plexus sheath. So sometimes what happens when you're giving the volume, it directly gets into the epidural and subarachnoid space and get into a locked in kind of a syndrome, like a total spinal. So just we had two big cases. After that, we have been very careful because we are not sure if the brachial plexus sheath is intact or broken off or torn off. This is one thing we need to keep in mind before we go ahead and give a block.
Right. Thank you.
Two small
there is-
comments if I can make. So even if you give subclavian perivascular with 10 ml of local anesthetic, you will definitely have some suppression of the diaphragmatic movement on ultrasonography. Although it is clinically insignificant, the patients will never complain of dyspnea or any respiratory discomfort. But objectively assessed, there definitely is some flattening, maybe 20% only of the diaphragmatic expression. And the technique that we are using, even with 10 ml of the local anesthetic in subclavian perivascular, if we have ensured that the corner pocket is well injected, we never get an escape of the posterior cutaneous nerve of the arm. These are two of my observations. Thank you.
There is a good evening, sir. Vipin here.
Yeah, Vipin.
Yeah. Sir, we have discussed about the mid-clavicle fractures and plating. But if we are going for nailing, like we were doing tense nailing also, then they have to modify a little bit of our technique. Because most of the time, for nailing in clavicle fractures, we have insertion point is on the medial end of the clavicle. So when you give the superficial cervical plexus block or with the upper trunk block, the medial end of the clavicle is not covered in that because there are cross fibers which are coming from the opposite side of the superficial cervical plexus also, you can say. So in that condition, we have to give local infiltration around the medial end of the sternoclavicular joint. So that's just point one to add, because these days people are doing nailing also in that clavicle fractures. So
Yeah, true.
infiltrate the sternoclavicular joint on the medial side from entry point, because there is a crosswise coverage from the opposite side also.
Azam, I just have a point. This is Ramkumar here. See,
Yeah, please.
good evening, everybody. See, also, when we are deciding whether we have to, I think we had a discussion about this some time back. See, the fracture fixation of clavicle is done when it is most of the times, they try to do non-surgical management if it is aligned well, and the choice is given to the patient or depending on the surgeon whether they want to fix it or not. So we need to understand the cases which come for a scenario where the clavicle fixation is absolutely necessary. So in such cases, what happens is, we had a discussion with the surgeons also about this. There will be a interposition of the muscle in between the fragments. So there'll be disruption of all this fascia, whatever we discuss, and the drugs may not be covering that whole area, so that the analgesia may not be sufficient. So this is one of the entities where we should be very careful in deciding whether we do it under block. As Vipin was rightly telling, the technique where some of the surgeons will do a nailing from the medial to lateral, and invariably we end up in infiltrating. So what I practice is, when there's a clavicle fracture, we give GA, but definitely the infiltration along the even the simplest infiltration all along the supraclavicular area with a medial infiltration will most of the times suffice. But we need to keep these things in mind. The interposition of the muscle, whatever the muscle come in there in between the fragments, can be an hindrance for a case to be done exclusively under a regional anesthesia. I think Mandana ma'am can tell me if she has got any such cases where still she has gone and done it, because I think they'll be doing larger volumes here.
Well, I don't think I'll be able to comment anything much on this because generally we don't get too many clavicles to be fixed, and they're generally doing it. They're the lateral ends or the medial parts, and they're fixing it with plates and not nails in our center.
We are
So
doing
we have not
regularly
faced this issue.
clavicle fractures, almost 3 to 4 clavicle fractures every week we are doing. And most of the time we are getting away with the blocks.
We don't do it so frequently. We don't do it so frequently.
We are giving upper trunk block and with the superficial cervical plexus block. If any COPD and obese patient, I avoid intermediate block preferably, and I'll give local infiltration like fan shape infiltration or the local infiltration around the incision site, because that will help me a lot by avoiding the phrenic nerve involvement. Only sedation is required because the patient, they will do surgery in the sitting position or head up position. So that time only just patient was very uncomfortable in sitting on the edge of the table because they want shoulder to be little outside the table and so that they can see the C-arm and all. So only for that we need a little bit of sedation. Otherwise, upper trunk and superficial cervical plexus block usually suffice.
Thank you, Dr. Ram. Before we move to next presentation, there is a question from Dr. Prerna in chat box. Does intermediate cervical plexus block cover the medial aspect of clavicle as well as for awake clavicle surgery? Comments from experts, Azam or Lakshmi ma'am. Dr. Azam, are you there?
Yeah. Sorry. I missed the question, Hetal.
It is in chat box by Dr. Prerna. Does
intermediate superficial cervical plexus cover the medial aspect of the clavicle as well as awake clavicle surgery? No, I don't think so. It does to some extent, but definitely you need to infiltrate. This is my take on this.
Yeah,
Yes.
definitely, I agree. I mean, that was exactly the reason why I started this conversation, because it all depends on whether we are dealing with which portion of the clavicle, and as Dr. Vipin, raised that the position of the patient, how comfortable they are, along with the pain control, we need to make sure, the patient is comfortable too. So that was the reason I was trying to see how different places are practicing the clavicle surgeries. Thank you, everyone.
Thank you, ma'am. So can we move to next presentation?
Yes.
Yeah. Sanghamitra.
Yes, sir. Srishavan, can you share your presentation, please?
Yes, ma'am.
Right.
So, good evening, everyone. My topic is on facial pain blocks and narrative review. So, this is an article done in published in Saudi Journal of Anesthesia in 2025. It is given by Dr. Tulgar. So, from the Department of Anesthesiology and Reanimation, Samson University. So, the article is basically facial pain blocks as the main anesthetic method and narrative review. So they've in this study they've done a narrative review to show that facial pain blocks as the main anesthetic technique. But before we get into the topic, we'll some basics about the facial pain blocks. So the facial pain blocks are definition. It is a group of regional anesthesia technique aiming to deposit and inject it, typically a local anesthetic in a facial plane, such that it spreads within a potential space to affect one or more neural targets. This was given in an article by Kasai and Costa. So what is fascia? Fascia is a specialized dense sheet of connective tissue composed primarily of collagen that traps, separates, and supports every muscle, organ, nerve, and bone in the body. So what is the main role of a fascia is it is mainly anchors the entire body, and it separates various parts of the body into particular compartments. So fascia can be divided into deep and the superficial layers. So superficial layer is between the skin and the muscle. So this superficial layer allows for pliable slide. It provides a pliable sliding interface for movement of the body, whereas the deep layer, which is the target, which is our target in case of a facial plane block, is a multi-layered facial layer. It consists with two distinct subtypes, which is the epimysial fascia, which is thin and adherent to the individual muscles, and then you have the aponeurotic fascia, which is thicker, fibrous, and often separated from the underlying muscle by an intervening layer of adipose tissue. So when we look into the layers of the deep fascia, we'll be looking into these layers, which is the fibrous layer, the loose connective tissue, and the hyaluronic layer, and the fibroblasts. So our target in this region will be a free nerve endings. Your free nerve endings, the fascia mainly acts as a sensory organ, which is richly innervated by polymodal free nerve endings, and including the unmyelinated C fibers and also the thin myelinated A delta fibers. These mediate your nociception and proprioception, which can lead on to the explanation for the pain following any facial injury or facial break. So we target these nerves, that is the free nerve endings and your A delta and your C fibers, unmyelinated C fibers, and also the somatic nerve fibers which cross through the facial plane. So mechanism of action. So you have various mechanism of action for facial plane blocks. First is the anatomical pathway dissemination. So local anesthetic in this anatomical pathway dissemination is that the local anesthetic spreads via the facial planes. It bathes the traversing somatic nerves that plexuses and other neural structures as it passes through the facial plane. And it can also sometimes spread into the paravertebral regions also. So then you have the volume mediated pressure gradient. So these are given facial planes. The injection is local anesthetic is injected in a pressure area with some amount of pressure. So this pressure will lead to hydrodissection of the facial plane and lead to more spread of the drug in a more longitudinal and a transverse direction. So this leads to more spread of the drug and coverage of more nerves. So indirect nerve contact, the local anesthesia diffuses through connective tissues to reach the nearby nerves without coming into without the needle coming in close by contact to the nerve. And there is also sympathetic chain and visceral modulation. The sympathetic chain can get involved mostly in your posterior blocks when the drug spreads medially and anteriorly from your posterior blocks, leading on to your sympathetic chain involvement. That is, the RAM-A communicants can get involved. And some amount of systemic absorption is also present in case of facial plane blocks. Then you have the neuroimmune and anti-inflammatory action. So local anesthetics attenuates the local neuroinflammation, and it also modulates the cytokine release. So these are the mechanism of actions of facial plane blocks. So your target of facial plane blocks, you have your non-cutaneous nociceptors and mechanoreceptors. Then you have cutaneous branches within the plane and the central modulation. The central modulation occurs via the wide dynamic range neurons in the dorsal horns. So what is the facial plane blocks inhibit the peripheral nociceptive inflow, leading on to modulation in the wide dynamic range neurons present in the dorsal horn. So this leads to secondary central analgesia. So what are the differences between facial plane blocks and perineural blocks? Your facial plane blocks, the target is mainly a facial tissue plane, whereas your perineural blocks, you have specific nerve trunk or plexuses. The needle placement in a facial plane block is away from the nerve, whereas in perineural blocks, it is adjacent or to circumferential around the nerve. You need more volume in case of facial plane blocks as compared to perineal blocks. The onset is somewhat slower compared to your perineal blocks, and often analgesia with sometimes without sensory losses present. Complication, lower risk of direct nerve trauma or hypotension as compared to your perineal blocks. So pharmacological consideration, as I said in the previous slide, we need more volume as compared to your perineal blocks. Since we can go for a lower concentration of the drug. So ideally for any facial plane blocks, 0.4 to 0.5 ml per kg of local anesthetic can be used, and adjuvants can be used, such as your epinephrine, your dexamethasone, which can prolong the block, but the systemic role is still debated. And continuous infusion catheters are also being used in case of facial plane blocks. So, and there is an increased risk of loss because of increased volume which we are giving, and when we are using continuous catheters, the chances of loss are even more, and strict dose calculation is required. So what are the factors affecting local anesthetic spread in case of a facial plane block? You have the facial fusion lines, which restrict the medial lateral and the cephalocaudal spread. An example of this is your linea alba and your linea seminonalis, which prevents spread of the drug in a longitudinal and in the transverse direction. additions of fibrosis post-surgery. When in any case of post-surgery, when we are trying to give a facial plane block, this can additions can be present in the fascia, which can prevent the spread of the block. Facial compliance and elasticity. So this determines the longitudinal versus the transverse diffusion. Injection site and depth. What location we are giving the injection and at what depth we are giving the injection also plays a role. The volume of the drug and the patient positioning. The patient positioning post-procedure has been given as to play a role in the spread of the drug. For example, in case of an erector spinae plane block, after giving in the prone position, because of the prone position, the drug may spread into the paravertebral space, can involve the ventral rami, giving a more better analgesia. And respiration, where there's change in intrathoracic and intra-abdominal pressures, which can lead on to cephalocaudal spread of the drug and also a longitudinal spread of the drug. So some of the important fascias which we'll be covering is your cervical fascia. Your cervical fascia has a superficial and a deep layers. The superficial layer covers the platysma, whereas your deep layer it is divided into the investing layer, the pretracheal and the prevertebral layer. So the blocks which we predominantly see here is the brachial plexus. Brachial plexus, as you can see in the image, is present between the anterior scalene and the middle scalene muscle, and it is enclosed by the prevertebral fascia. Because of this enclosement of the prevertebral fascia, most of the complications occurring by giving interscalene brachial plexus because of this, plexus presenting plexus being covered by the prevertebral fascia, that can spread into the adjacent structures such as the phrenic nerve, and it can involve the sympathetic chain lead from your occiput and ma'am. Hello.
You're losing your network in between.
Able to hear me, ma'am?
Yeah,
Shall I
yeah.
continue?
It's okay. Yeah, yeah, please.
Yes. So the cervical fascia. So the complications are also present because of the adjacent structures being enclosed in the same facial layer. So this is what I want to convey. Cervical fascia extends from your occiput to the C7 vertebra, and then it envelops the entire neck. So then the next fascia is your endothoracic fascia. Endothoracic fascia is like a barrel enclosing your thoracic region. So it is present deep to the transversus thoracis muscle and superficial to the parietal pleura. So the endothoracic fascia is also extends from above from the it extends above from the suprapleural membrane, and it goes down up to the continues as the continues with the thoracolumbar fascia. That is a posterior layer in case of the posterior region. So this is about the endothoracic fascia. Then you have the thoracolumbar fascia. Thoracolumbar fascia, you have the three-layered model. You have the anterior layer, the middle layer, and the posterior layer. The anterior layer is present in front of the QL muscle and the psoas major muscle, and as you go, the middle layer is present in the behind the QL muscle, and behind the erector spinae muscle, you'll be able to find the posterior layer. The extent is from the 12th rib, and it extends to the iliac crest, and it attaches to the vertebral body. Transverse process in the vertebral body, and it on the lateral side, it goes up to the lateral raphe. So this is to show a continuity of the fascia. So the continuity of the endothoracic fascia continues with the anterior layer of the thoracolumbar fascia. Picture depicting the continuity of the two fascias present above and below. So then we have the fascia transversalis. The fascia transversalis is located deep to the. So the fascia transversalis is located deep to the transversus abdominis muscle. So transversus abdominis muscle, the fascia transversalis continues above with the diaphragmatic fascia, and as it comes down to the fascia iliaca, and it goes to the continues with the pelvic fascia. So, and then you have the fascia iliaca, which is the fascia overlaying the iliacus muscle and the psoas muscle, and then the fascia lata, which is the fascia covering the entire thigh region. It's also similar to the endothoracic fascia, barrel-shaped fascia. So the aim of this study, that this journal, is to shed light on the possibility of considering facial plane blocks as an alternative anesthetic method for appropriate procedures in patient groups with high mortality and morbidity. So it is also to discuss the surgical procedures and possible facial plane blocks and its combination. So according to the study, for breast and thoracoscopic surgeries, So this is the nerve supply which we'll target, which is from T1 to T6 spinal nerves, that is intercostal nerves. Then you have the anterior cutaneous branches, the supraclavicular nerve, the pectoral nerves, and you have the intercostal brachial nerve, the thoracodorsal, and the long thoracic nerves. So according to the study, blocks used for your non-intubated VATS surgeries are your serratus anterior plane block and your erector spinae plane block and a rhomboid intercostal block. And for your breast surgeries, you use your pectoralis interpectoral plane block and pectoserratus plane blocks. And then you have the serratus anterior plane block and your parasternal blocks, which will cover the medial breast innervation. So the facial plane which we are targeting for your for these surgeries will be, so this is from the Delphi consensus. So from the Delphi consensus, your sorry, excuse me. Here in the chest wall blocks, here have the superficial serratus anterior plane block. In this, the injection is in the plane which superficial to the serratus anterior muscle. So this is a facial plane block. Then you have the deep serratus anterior plane block. Injection is between the posterior surface of the serratus anterior muscle and the periosteum of the rib. Then you have the superficial parasternal intercostal plane block. Injection in the plane superficial to the internal intercostal muscle and the ribs and deep to the pectoralis major muscle. Then you have the deep parasternal intercostal plane blocks, injection in the plane between the internal intercostal and the transversus thoracic muscle. Then you have the interpectoral plane block, injection is between the pectoralis major and the pectoralis minor muscle. And they have the pectoserratus plane blocks, whereas the injection is between the pectoralis minor and the serratus anterior muscle. So this is an image depicting the various plane blocks. Pec1 is between the pectoralis major and the minor. So you will be targeting the pectoral nerves. And in PEC1 or your interpectoral plane block, and then you have the PEC2 or the pectoserratus plane blocks. Again, you'll be targeting your pectoral nerves, which is between the pectoralis minor and the serratus anterior muscle. Then you have the serratus anterior plane block, which is the superficial and deep. And then as you go posterior, you'll be having the erector spinae plane block and the paravertebral block. So in the anterior chest wall, we'll be covering the anterior cutaneous nerves. And in the lateral chest wall blocks, such as serratus anterior plane blocks, you'll be covering your lateral cutaneous nerves. And in the posterior block, you'll be covering the dorsal rami, such as your erector spinae plane blocks. So this case report, they have done multiple surgeries. And so for according to the study, the video assisted VAT surgery, they're using erector spinae plane block and your serratus posterior superior inferior plane block and a rhomboid intercostal and subserratus plane block. And then for breast surgeries, we are using the interpectoral plane block. Breast surgeries, it is not a single facial plane block can be used. We have to use a combination of plane blocks, facial plane blocks to cover the innervation of the breast. So for breast cancer surgeries, they are using the interpectoral plane block and the pectoserratus plane block and the serratus anterior plane blocks. And they're also using the erector spinae plane blocks and the paravertebral blocks also. So for spine surgeries, we have the erector spinae plane block, the retrolaminar block, and the paravertebral block. And then you have the midpoint of transverse process to the pleura block. And then you have the thoracolumbar interfacial plane block. So again, in this, we'll be targeting your dorsal and the ventral rami of the spinal nerves. Predominantly, the dorsal rami will be blocked, and if the drug spread again based on the gravity and various other factors that we previously discussed, and drug spreads into the anterior portion, then you will have a ventral rami blockade also. So erector spinae plane block, according to again to the Delphi consensus, so you have your erector spinae plane block is an injection in the plane between the erector spinae muscles and the transverse process. Then you have the paravertebral block, injection in the paravertebral space, that is between the superior costotransverse ligament and the parietal pleura and the thoracic region. Then you have the retrolaminar block, which is injection between the erector spinae muscles and the lamina. Then and the intertransverse process block at midpoint of the transverse process to the pleura block also. Injection is between the two transverse process, posterior superior costotransverse ligament, or halfway between the posterior aspect of the transverse process and the pleura. That is between the halfway between the transverse process and the pleura. So erector spinae plane block, we will be giving between the transverse process and the erector spinae muscle. We will be predominantly covering the dorsal ramus. And then the needle insertion point, comparing the various posterior wall blocks, we'll be giving your retrolaminar block, which is posterior to the lamina, the paraspinal or the intercostal block, which is posterior to the rib or the transverse process, the erector block, which is posterior to the transverse process, and the midpoint transverse process to the pleura block, which is posterior to the transverse process. So we'll be in the needle point will be contacting the lamina in case of retrolaminar block, and it will be paraspinal intercostal block, it will be contacting the ribs. In case of erector-spinae block, it will be contracting the transverse process. And in case of the mid-transverse process to pleura block, it will be the needle will be halfway between the transverse process and the pleura. So predominantly, a dorsal rami will be covered in all these blocks, and ventral rami spread is more common with your paravertebral blocks, and sometimes with your erector-spinae block based on the positioning and various other factors which we have discussed prior. So the thoracolumbar interfacial plane block, it is given in the erector-spinae muscle, the multifidus, the longissimus, and the iliocostalis. So when the drug is given between the multifidus and the longissimus, it is called as thoracolumbar interfacial plane block. And when it is given between the longissimus and the iliocostalis, it is called as the modified thoracolumbar interfacial plane block. How do we identify the multifidus muscle? We identify the spinous process, and just lateral to the spinous process, the multifidus muscle will be present. It will be and there will be varying echogenicity between the multifidus muscle and the longissimus muscle. So paravertebral block, we'll be giving in the paravertebral space just after piercing the superior costotransverse transverse ligament and above the pleura. So this gets the ventral rami also gets involved as the drug spreads into the paravertebral space, and it also can involve the sympathetic chain also, and some amount of hypotension can be expected in case of your paravertebral blocks. So overview of the facial plane blocks for spinal surgery. Various surgeries, they're predominantly using and the vertebral blocks. So for abdominal surgeries, again, various blocks they're using in this particular study. So we'll be covering about the rectus sheath block and the transversus abdominis and the quadratus lumborum plane block. So the target area is the anterior cutaneous nerve in the rectus sheath, the T7 to L1 nerves in the tap plane, and the thoracolumbar fascia near the quadratus lumborum. So the main difference is with the quadratus lumborum, you will have some somatic and some visceral components also will be involved, and it has a more wider coverage, and there can be some amount of paravertebral spread there, according to various studies. And whereas the rectus sheath block, we're predominantly using for a midline incision, and your anterolateral abdominal surgery, that is your lower abdominal and lateral surgeries, will be using your tap block. So according to the Delphi consensus, the rectus sheath block is an injection in the plane between the rectus abdominis muscle and the posterior rectus sheath. And then your transverse abdominis plane block is an injection in the plane between the internal oblique and the transverse abdominis muscle. Then you have the subcostal transverse abdominis plane block. It is the internal oblique and transverse abdominis muscle along the medial costal margin. Then the QL block, it is being divided into the anterior quadratus lumborum, the lateral quadratus lumborum block, and the posterior quadratus. In the anterior QL block, the injection in the plane between the quadratus lumborum and the psoas major muscle. Whereas in the lateral QL, the injection in the plane between the aponeurosis of the internal oblique and transversus abdominis muscle at the lateral border of the quadratus lumborum. And in the posterior QL block, you'll be injection is in the plane between the quadratus lumborum and the erector-spinae muscle. So if you can visualize from the psoas major, the QL and the erector-spinae from the anterior to posterior. So between the QL and the psoas major will be the anterior, and the lateral QL will be at the lateral border of the QL muscle, where it continues with the transversalis fascia and in the internal oblique aponeurosis. And then the posterior QL will be between the QL and the erector-spinae muscle. So rectus sheath block, you have the rectus muscle and the posterior rectus sheath. Then you have the quadratus lumborum block. So as the needle pointer images, see the anterior QL is between the psoas major and the QL muscle, whereas the lateral QL is present at the level of the lateral border of the QL muscle along with the aponeurosis of the internal oblique muscle, and the aponeurosis of all three abdominal muscles, and it continues somewhere near the transversalis fascia also. And the posterior QL is between your QL and your erector-spinae muscle. So various studies have been, they've compared various case studies and case reports and for various abdominal surgeries and mini laparotomies, open areas. Predominantly, we are using for open area QL blocks and your thoracoabdominal plane blocks and your erector-spinae plane blocks are being used. So for various orthopedic procedures, as previously discussed, for clavicle fractures, we are using your upper trunk and your clavicular fascia plane blocks and your superficial cervical plexus or your intermediate and deep cervical plexus block being used. And for hip surgeries, lumbar and spinal plane blocks, interscalene block is used for the scapular surgeries. And according to these studies, these are the case reports which they've done, and these are the blocks which are being used for the orthopedic procedures. So for some of the upper limb procedures, we are using the interscalene brachial plexus. As previously mentioned, it is enclosed within the prevertebral fascia between the anterior scalene and middle scalene muscle. So we'll be giving the prevertebral fascia is breached and the drug is being given. So in the suprainguinal fascia iliaca block, the nerves blocked we are targeting is your femoral nerve, lateral femoral cutaneous nerve, and the obturator nerve. So this is the fascia iliaca covers the iliacus muscle. So we'll be seeing the tapering end of the internal oblique and the sartorius muscle forming the bow tie appearance, and you'll be able to visualize the deep circumflex iliac artery. And just below that, you'll be able to see the fascia iliaca, and drug is deposited to split open the fascia iliaca. As you can see in the image, post-injection, the splitting of the fascia iliaca is visualized. So clavipectoral fascia plane block, anatomical target is injection between the clavipectoral fascia and the periosteum of the clavicle. The local anesthetic spreads along the clavicle and blocks the terminal sensory branches. The nerves covered are your supraclavicular nerve, and contributions from the subclavian and pectoral and the periosteal nerve fibers are also present. So the conclusion from the study is that the anesthetic management can be achieved using facial plane blocks as well as peripheral nerve blocks and plexus block. However, it is important to work closely with the surgical team and be aware of the complications and unexpected difficulties that these techniques may present. So these are my references. Thank you.
Over to you, Dr. Azam and Dr. Lakshmi.
Nice presentation, Dr. Shravan. As you rightly said, and the journal states that we all believe in please do no harm, and especially when we are choosing these facial plane blocks, which are absolutely helpful nowadays, especially in the high risk population. But when we say high risk population at the same time, it's very important that we don't burn our bridges, because there should be a very good communication between the anesthetist and the surgeon, and the anesthetist should have a complete knowledge of what the surgery is about and the manipulations, and to what extent the surgery is being done. And sometimes they say unproceed. So if at all they're proceeding to something else, and what is our plan B? And looking at our difficult airways, and if sedation is needed, then we don't want to burn our bridges, because high risk population, when we are giving sedations, as you know, it might tip the burn the bridges too. So I think a good communication between both the parties, and as you said, anticipating the complications and having a plan B, I think would definitely help us when we are choosing these facial plane blocks for sole surgical anesthesia technique. Thank you.
That's an excellent presentation, Shri. So I just wanted to understand a few things. Okay, when you're giving a facial plane block, where do you think the local anesthetic acts?
Sir, the facial plane contains free nerve endings, sir. These free nerve endings, they'll block, sir. The free nerve endings contains your unmyelinated C fibers and your A delta fibers also, sir. So the nociception and proprioception is also blocked, sir. And then as the somatic nerve traverses via this plane, sir, there is indirect action of the local anesthetic on these somatic nerves and these plexuses, leading on to blockade and leading on to anesthesia, sir. Analgesia.
So in myelinated or in non-myelinated fibers, where exactly the local anesthetic acts? In a non-myelinated fibers. So it acts on the entire axon.
Okay.
So in myelinated nerve fibers, very simple that it acts on the nodes of Ranvier. So you also mentioned the mechanism of action of analgesia, analgesia or anesthesia. I missed that point. So how do you think the mechanism, because I have read this article, it says multifactorial. So how do you think the mechanism of facial plane blocks for analgesia acts?
Sir, based on article, sir, multifactorial is basically the free nerve endings present in the facial plane is also blocked, sir. Then your somatic nerves will be blocked, sir. then the spread of the drug is because facial planes, there's some amount of there are closed space. When we are injecting drug at this closed space, the spreading up of the fascia will lead on to some hydrostatic pressure leading on to push of the local injectant across the facial plane. So when the drug spreads more, more area is also covered, sir. That is one of the methods, sir. Then you have your sympathetic blockade. Sympathetic blockade can occur if based on various other factors such as your positioning and your respiration, and if the drug spreads into your paravertebral, predominantly it occurs in your posterior blocks, wherein the drug spreads into the paravertebral and sympathetic chain is involved. Sir. When the sympathetic chain is involved, it can lead on to sympathetic blockade. And since the local anesthetic itself is attenuates your neuroinflammation, it also has its own action via that pathway, sir.
Perfect, superb. And in fact, it blocks the facial nociceptors, right?
Yes, sir. Facial nociceptors and mechanoreceptors and
True.
And proprioception, sir.
True. So in myelinated, in non-myelinated nerve fibers, at least 8 to 10 mm of nerve should be blocked for it to act, and at least 2 to 3, node of Ranvir should be blocked for local anesthetic to, act successfully. Now, when you consider these nerves, where do you think the local anesthetic receptors are located? Because now the facial plane blocks are emerging so much, and an excellent article. Request everybody, all the fellows, to go through this article. I mean, hats off to the Ganga team that has written such a beautiful article. So can you just tell me where exactly the local anesthetic receptor is located on the nerve? Shri, you there?
I'm not sure, sir.
Oh, no worries. So basically the intracellular side of the voltage gated sodium channels. So specifically in the inner pore region of the alpha subunit, and the most binding occurs when the channel is open or inactivated. So this brings to a topic called, what is mantle effect? Any idea what is mantle effect? MANTL.
Mantle is your peripheral, when the nerve fiber is divided into peripheral and your core fibers. So the peripheral fibers will be involved first and followed by your core fibers. So.
Correct. The outer zone, based on the, it is basically in mixed peripheral nerves where the outer zone is proximal fibers and the core is the central fibers. But what is its anesthetic implication? Why are we discussing this?
Sir, if only the mantle fibers are blocked, the anesthetic technique will involve there'll be differential blockage, or some amount of your peripheral muscle region can be blocked more compared to your more central regions.
So the mantle effect refers to what? A preferential blockade of the outer nerve fibers before the inner nerve. That is what it says. So when the local anesthetic diffuses from outside of a nerve to the center, that is the core of the nerve, right? Because local anesthetic reaches the outer fiber first. That is a very simple explanation. But what is its anesthetic implication is because what happens is, if local anesthetics block the sodium channel, and more effectively when the nerve is actively firing, and the more frequent a nerve fiber, the more channels are open and the more local anesthetic can bind. So if it does not happen, then it leads to a patchy block, delayed distal analgesia, could be motor sparing, and these are the few local anesthetic effects that can happen. What is the sweet spot of the nerve? Which is the sweet spot of the nerve for the plexus and nerve blocks? It is the subparaneural space. So ideally the injection site, like, inside the common paraneural sheath, but outside the epineurium of an individual nerve. So this is called as the subparaneural. So not the intraneural or the extraneural. So when it comes to the facial plane blocks, the sweet spot, the ideal site for local anesthetic deposition, is where between the two fascia, where it reaches the nerve effectively without any intraneural injuries and without intravascular injection. Because I think there was one article where the tab block was given and they had a local anesthetic systemic toxicity, if I'm not mistaken. So now it is called as the dynamic, the facial plane block. Before we thought it was a static layer, but not anymore. They're called as the dynamic. Fascia is a very dynamic tissue. That's a new concept because it's biologically active. It has Which type of nerves are seen in facial plane? You said something, right?
Yes, sir. Your unmyelinated C fibers and your A delta fibers are more common, sir.
Absolutely.
And your pre-laminic sir.
And C fibers are very resistant, right?
Yes, sir.
Correct. So the microanatomy, if you see the microanatomy of the fascia is like free nerve endings, that is C fibers, A delta fibers. They have fibroblast and hyaluronic acid matrix. That's why these facial layers are very, very tight in patients who are above 65 and plus age group. Fine. I'm done, Hedalbhai. I think if anything is there, or Vipin or
Thank you, Dr. Azam. Any comments from other experts? Anju is there, Vipin is there, Vandana ma'am is there, Vrushali ma'am was there. I don't know.
Can I make a small comment, Hetal?
Yes,
I'm
yes,
not
ma'am.
doing it, but one of my colleagues is using the tab block. They give 4-quadrant tab with 10 ml drug in each quadrant. After induction, in laparoscopic colysis technique, after induction, before insufflation of the pneumoperitoneum. And they say they have excellent results with good hemodynamics and good postoperative analgesia to the extent that their surgeons ask for the block. I have not done it. They have just communicated it.
Thank you, ma'am. Any comments from Vipin, Vrushali ma'am? Anju is there.
I was listening to the talks.
Yes, ma'am.
Yeah, I do understand the nitty-gritties. I do understand the depths of what has been discussed, and it's amazing to see how much more we can know in facial plane blocks. I sometimes feel facial plane blocks itself is a misnomer. It's not a facial plane block. It's actually a facial plane injection. I just feel we should be changing the terminology altogether. There is if we pick up a nerve and then we go and block the nerve. So this is more of a spread and injection and the space that matters more than a particular point of needle tip to be. I mean, it's a space which you should look at it from a different angle. And the unpredictability of facial plane blocks has to be respected, understood, so that we do not we understand the limitations of it.
Yeah, that's very important.
Hedalbhai, one last question to Sri, because Madam has asked the question of limitations. What are the limitations, Sri?
Sir, one of the limitations is when the drug spreads away. We are not exactly sure because we are giving it in the plane. We are visualizing some amount of the drug spread, sir, but how much extent of the drug spread exactly we won't be able to say, sir, and it varies based on various factors, sir.
Correct.
So if based on the age and based on the patient's respiratory efforts, positioning, and the volume which we give, all these things are a factor leading on to a change in the drug spread. So exact drug spread cannot be we cannot be very accurate with the drug spread and our coverage, sir.
Sometimes I wonder with facial plane blocks, when the volunteer studies were done and they mapped the analgesia that they got, it was so varied that I wondered, I mean, what exactly are we achieving? Hence, we need to be very mindful about what we are using it for. We need to be very mindful about what multimodal approach shall we be keeping so that the pain control remains very clinically sufficient. And the last part is I want to know from our students is knowing the vagaries of facial plane blocks. What would be that one facial plane block which is pretty much consistent? And why would the nature of that block be so? It's pretty consistent. Once you give that block, you're quite sure it works. So which one and why? You can take a guess.
Anyone wants to answer from fellows?
Interscaling block can be your effect is pretty sure, ma'am.
Sorry?
Interscaling block, ma'am. It is a facial plane block. We pierce the prevertebral fascia and we give.
Okay, if you want to look at it that way, fine. Abdominal, let me come to abdomen. If I imagine it, I feel the rectus sheath block is the most consistent block because the facial plane is not that much for the drug to travel and reach. So bilateral rectus sheath block should give a consistent analgesia at least for the umbilical port is what has emerged from the practical experience I have with facial plane blocks.
Ma'am, what's your take regarding thoracic paravertebral block for consistency?
Thoracic paravertebral block for consistency, I feel, and it's what I have seen in through my practice, I can tell you it's a reliable block. But now it depends upon how you use it also, how many segments you block. Because whenever I have done breast with aortic stenosis or something like that, say 91-year-old, in paravertebral block, yes, it works pretty consistent, provided we pick up those right sites and we also supplement it with the anterior thoracic wall blocks. That is the time I feel they work the best. Theoretically, it should be giving analgesia every time we work.
Yes, ma'am.
Vishali ma'am, regarding my experience for abdominal surgeries, especially laparoscopic surgeries,
Yeah.
I have found anterior QL block very consistent.
Definitely, yes. Anterior QL, yes, I agree with you.
Excellent
Yeah,
anatomy.
I see that point. In fact, in say appendix, say for a laparoscopic appendicectomy, on the right side if we give QL, and on the other side if we give just a tap and the rectus sheath, because it's more for the port, and more often more of the dissection is on the right aspect. Yes, QL does give rather a consistent coverage. However, that does not take away paracetamol and NSAID from the prescription.
Definitely,
Yeah.
ma'am.
So, yes. So, facial plane is synonymous with multimodal analgesia. We
Yes.
may go in the depths and the depths of microscopic anatomy, electronic microscopic anatomy, but look at the overall picture as well. Understand it beautifully, perfectly well. Understand the limitations, students. And finally, your aim is to keep your patient pain free in the post operative period.
Absolutely.
Agree.
Other point is it is a volume based block.
Yeah.
You
Yeah.
have to monitor it post-op also for a long time. Because you have given a long volume and it is most of the thing will get systemic absorption will happen. So we don't know
Last.
it will get
Yes,
time
Vipin. Yes,
to
yes,
absorb
yes.
and when it will reach the and ultimately
Definitely.
we can say also killing the art of regional anesthesia we can say because we don't know whether it is working by blocking the nerves or by
Yeah.
getting systemic absorption and reaching the level in the blood that a local anesthetic level and working through systemic
Yes.
absorption.
I want the students to really imagine that whatever you place in the body, no matter how precisely you're placing, final destination is blood. It is going to get into the intravascular compartment. Be very, very mindful about what you inject, where you inject, and how much, and be watchful in proportionate to what you have injected.
As compared to regional like nerve root blocks, this block we have to monitor for a longer duration.
Yes.
Definitely. And even in pediatric surgery, especially because the surgery get over before, the peak effect, peak
Yeah.
systemic levels would be there. Sometimes surgery gets over in 20-30 minutes, and we might
Yes.
not be, so watchful after giving a block. So like, and also we have to be very careful about the doses used in pediatric patients. They are not the same as adults, not the fixed volumes which we use in adults. So they may be as low as 0.1 to 0.3 ml per kg. So definitely we have to be very watchful.
And in children or pediatric patients, we should remember that hyaluronin is very, very less as compared to adults. And the fascia is very soft.
Yeah.
Yeah.
And
Spread
as Vipin
is
was mentioning, the local anesthetic are called as local anesthetic guzzlers. In the sense, when you're using a facial plane block, it just drinks local anesthetic as well. You can keep giving and it keeps. So chance of
Yeah.
loss is very high. The other issue, what I've seen with the facial plane block is inconsistent dermatomal coverage
Absolutely. Yes, yes.
and variable or unpredictable local anesthetics,
Yeah,
right?
yeah.
And also the visceral analgesia, madam. It's
Yeah.
Where
little
is it?
That is
Other than
lacking.
QL, who is going to give us
yeah.
visceral analgesia?
And I strongly feel, because at the end of the day, my patient should be happy and my surgeon should be satisfied. I think that is the end point of.
Very true. Oh, very true. Because no face abdominal wall blocks are that is what they are. They will block the abdominal wall. That's
Yeah.
it.
So
So
we have
that
to.
is also a good bet if we have other issues such as coagulopathy and stuff like that. We can. I think we are underestimating a well-placed central neuroaxial block for a very, very major surgery or even a robotic surgery which goes for hours and hours because it just decreases, drops the amount of general anesthesia you would give, drops the amount of opioids we would give, drop the amounts of post-operative painkillers that one requires. So a well-placed thoracic epidural is given for a good robotic abdominal surgery. I mean, what I'm trying to tell you is you're going to be the future. You're going to pick up your needles and syringes and local anesthetics and give blocks. You are going to know so many blocks, but pick that one block up for your patient so that it covers all that in the best possible manner that is operated upon, and try and prolong it. And now, with this concept, go learn all the possible blocks and then pick up the one which will suit your patient the best.
In fact, I agree, madam, because the what I see of late is the run behind knowing majority of the
Yes,
blocks.
yes,
I
yes,
don't
Amrita.
think that is good with the present.
Yes,
Maybe
Azam.
Absolutely, I agree.
Yes,
because people,
yes,
oh, you
Azam.
don't know that
Yes.
block, oh, you don't know lumbar plexus block. Arey, give a block that works for a patient. No? I
Yeah.
mean, don't give a block that works for you.
Yes.
Hmm.
Yes, or you like it. I
So
mean, yeah, I understand, but then they are AORA students. They need to be answering exams and passing too.
yeah.
So they must do that. So
Hmm.
go all out, accumulate and assimilate all the knowledge. But it has to be finally that one block. Pick it up, which will help your patient.
Facial plane block, one thing which I like about it is that we can formulate the analgesia plan using various types of facial plane blocks for a particular procedure. Like Vandana ma'am mentioned that somebody is using 4-quadrant tap. So there are so many options to choose from, and we can, limit only to the area which needs to be blocked. Like lap chole, you may need only unilateral hemi-abdomen along with the rectus sheath block, which will cover the port, umbilical port. So that will cover the hemi-abdomen and the area for the surgery. You do not need to give random blocks and which are like uh, uh, the area which are not needed to be blocked. So you can customize and formulate the plan for a particular procedure because there are so much options to choose from, and you can minimize the volume also if you choose correctly. So, in my
Fully agree
opinion,
with.
lateral tap would not be needed for the left side in lap chole. I have done a lot of procedures, I have tried lot of blocks for lap chole, and what is consistently working is either subcostal tap on right side along with rectus sheath block on the left side, or EO block, external oblique plane block on right side along with rectus sheath block on left side. That works quite well. Almost no need of any rescue analgesia along with the basic multimodal. So,
Yeah,
uh,
Anju, can I tell something? For me, it's local infiltration along with the intraperitoneal installation works like anything. And for myself also, for my appendectomy, I asked my anesthetist to do local infiltration only, and it worked almost like 8 to 10 hours. So for laparoscopy, I will say nothing like local infiltration, in my opinion, of course.
sir, I would agree on the intraperitoneal installation because we were doing it a lot before the facial plane blocks were invented. So we have tried all adjuvants also. We were mostly using ropivacaine and before that bupivacaine. And then we combined it with some tramadol also, and sometimes even dexmedetomidine and other clonidine kind of things. And it definitely it worked beautifully along with local infiltration. So that combination was very good, and I think it is underexplored.
Yeah,
But
exactly. And recently, like for last 1 or 2 years, we are for intraperitoneal installation, we dilute a lot. Like we are taking 0.5% ropivac and 20 ml, and we dilute up to 100 ml. So it is very much diluted, like 0.1% ropivac. But
yeah.
if you increase the volume, it works well, in my
Yes.
opinion.
Sir, we used to use 20 ml over the gallbladder bed. What like intraperitoneal installation, which you are saying, the surgeon through the camera port used to instill 20 ml over the bed, and that works
Yeah,
quite good.
yeah, earlier we were doing same, but for last 1 or 2 years, especially in bariatric, we have started using larger volumes, and
Okay,
it
sir.
works even better. Try it.
Okay, sir. Sir, our surgeons are like very impatient about the blocks. If we give it in pre-op, then it is okay. Facial plane blocks and all, they don't give us extra time. So recently, I remember one case I instilled this intraperitoneal, this ropivacaine along with clonidine, and the patient post-operatively was absolutely pain-free. And the surgeon himself told me after seeing the patient in post-op that your installation worked beautifully, and it is a very good practice, and I would like to do a RCT on that. So that is one case which recently I remember. But I
So
am
you can compare 20 ml to 100 ml or 50 ml, whatever.
oh, that's a good idea, sir. That's a very good idea.
Yeah.
Off late, but I am doing more of facial plane blocks, sir.
Yeah, but for intraperitoneal installation, I am
Yeah,
telling.
yeah, yeah. That will be a very good idea, sir. But
Yeah.
ideally, do you think, sir, we should be doing this systemic level of local anesthetic for such kind of a surgery, such kind of blocks?
Uh,
100 ml, you are
uh,
saying,
but it is diluted,
but it
like
is diluted.
0.5% ropi.
Yeah.
Yeah, yeah. So it is roughly 0.1% ropivac.
No, you
Okay, sir.
better,
So it will be
when we
within.
dilute, we better keep milligram per kilogram the same, no? We
Yeah.
can't be exceeding that.
Yeah, it's same. Exactly, ma'am.
Absolutely, it has to be in the yeah.
It will be within
Uh,
safe limits. Yes.
Yes, it
so,
better
Yes, sir.
be that
so
way. It better be that way.
Yeah, yeah, yeah.
yeah. And one
I,
more thing, when we are instilling it into highly absorptive surfaces like the pleura in the peritoneum, then it's always a good idea to add some about 1 in 2 lakh of adrenaline to delay the absorption. There's a very, very old paper of 80s where they have reported that with safe calculated doses, at one point of time, the blood levels of bupivacaine exceeded the toxic level. So adding adrenaline will delay the absorption.
that's a good idea, ma'am.
If, my dissertation was on that, on interpleural block, and we operated on this philosophy because we
Ma'am,
were using
intrapleural,
20 ml. Yeah,
as you,
I,
you mentioned intrapleural, we were using it rampantly in Safdarjung when I was in Safdarjung. There it is utilized a lot, intrapleural. Even till now, sometimes they give intrapleural, and I have seen
so
it work. I have seen it work. Maybe the
it
risk
works
profile,
beautifully.
yeah, maybe the
Used
risk
it
profile,
for
maybe the risk
post-operative
profile is
open
not favorable.
polycystectomy.
Now hold on,
Yeah.
hold on. Let's get back. Let's get back here. Yes, I know. I understand these are very tempting thoughts to think about and go into the depths of it. However, remember the intrapleural block was something that, and even the facial plane block concept as such, it somewhere can act as a systemic local anesthesia going there because interpleural block has an absorption rate which is so phenomenally high. The highest absorption after
Yes.
penile
Yes.
probably is in there. So in today's day and age, I think when we have something like paravertebral or the other plane blocks, if at all plane injections, if at all we are considering, that would be a better way to deal with. And these blocks were there, are there. However, there are limitations of these blocks which are a little more than others, and hence RA today does not consider them as one of the best blocks to give.
Definitely, ma'am. Risk profile would not be
Yes,
favorable.
it's not that good.
Yeah,
Yes.
in one of the article, it is considered as a RIP block also, if I am not wrong.
Yeah, exactly. Yeah.
Any questions from fellows? questions from fellows? Any other comments from experts? If we have no question, can we conclude the session?
Yes, sir. So, as we come to the end of this session, I am happy that next.
Sanghamitra, you conclude the session. Can I tell something?
Yeah, yes, sir, please.
So I've posted regarding recording a video about supraclavicular and interscalene block. So I will insist all fellows to record that video and post on the group. It will help you to understand it in a better way. And once you record it and post it on group, you will get comments from the experts and you will learn more. We have observed during examination, students are struggling sometimes for easy blocks like interscalene or supraclavicular. So it will be a learning process for you. So I request all fellows to record the video and post on the group. Over to you, Sanghamitra.
Yes, thank you, sir. As I was listening to this talk on interfacial plane blocks, we can continue Rushali ma'am and Anju ma'am and Vanda ma'am next month in the master class, which will be taken by Amit sir. I will declare the date and time soon. However, we will all join back on 9th, a day after, for the master class by none other than our Vaibhavi ma'am on simulation in regional anesthesia. I welcome you all to join this session on 9th. This session is not only for the Aora and hybrid fellows, but this is also for the consultants. And believe me, ma'am is going to make it an epic masterclass. So I would like all of you to join us back on 9th, please. Thank you. Thank you so much for the today's session.
Thank you. Good night.
Good night, sir.